fairly quickly. I feel like you guys are doing a lot of these things. But I just want to talk about some sort of big picture care coordination program best practices. So the devil's in the details, and as I said before, the research shows this, PCDC's experience shows this, that, you know, there's no two programs that are really the same model, although there are multiple models, and you may want to try to emulate a particular model in your care delivery program. So the first kind of piece is about targeting the people for your program. And I guess kind of what I'm hearing, my sense is, and tell me if I'm wrong, that this is not really an issue for you guys, right? Like you have, or is it?
It depends.
So, you know, it seems kind of basic, right? Like target high need, high risk individuals, and you know, the research says like the programs that actually have a clear process for how they target individuals that need care coordination are the ones that do the best, and they use a combination of quantitative and qualitative measures to do that. So do you know what I mean by that, quantitative and qualitative? Mm-hmm. Do you want to give me an example of what that might look like? So that might mean that maybe you target people with chronic medical conditions, right? So people with particular diagnoses or lab values, but it also might mean in terms of qualitative that you look at other kinds of issues like do they have unstable housing? You know, is there some way to see if they have food insecurity? Like these other less, you know, like it's not a lab value kind of thing, but that you know add up to a higher risk individual, right? So this is probably, this is an ongoing thing, but a clear process for identifying the individuals that are going to need your services. So sorry to the folks who do telephonic, and I know that telephonic is a need in a big, you know, in a rural state, right? Not everything can be in person. I'm simply the messenger here, which is that the research shows that in-person care coordination is the most effective. But I would say that, you know, that doesn't mean that's better than, you know, you don't want no care coordination. If telephonic's all you got, that's all you got. But in terms of thinking about your program and building in things that lead to success, in-person and frequent interactions with your clients is really showing success. And warm handoffs between patients and providers results in better patient engagement. So we talked about warm handoffs in the core training, I believe. What do you do? Do you know what I mean by this? Who wants to tell me what I mean by this?
It's literally like if the doctor or somebody identifies a patient who could use care coordination. Well, in my area, we try to say, I have somebody I want you to meet. And just go grab, usually in our situation, it's a social worker, and just in for that 3-minute, hi, I'm listening, here's the things I can help you with, here's when I have time, please come see me again.
Right, right. So do others use warm handoffs in terms of engaging clients? Yeah?
The same thing, but it's not medical, it's the case management. So when cases are transferred to a new case manager, or we're introducing the mental health clinician, we'll have her come into a meeting with the case manager and say, here, that way it feels a little bit more comfortable for clients.
Right, because remember, right, there's that person, that patient, that client on the other side of it, right, who's going from one place to another. So warm handoffs really build trust and usually lead to people coming back, as opposed to things like, and I don't have a sense you guys do a lot of this, like in New York there's a lot of cold calling and knocking on people's doors, because we have a whole state program where, you know, the state wants everyone to outreach to these high risk people, and you know, I always say, like, I don't pick up the phone if I don't know who's calling me. Why would you expect a low income person to do that, right? That doesn't make a lot of sense. Like, trust is built usually in person. Okay, so have a strategy for transitional care. So this is really just thinking about, I mean, how many of you think you do have a strategy for looking at transitions of care for your clients? Yeah? Most? Some? Who feels like, well, I don't really have a strategy for transitions of care? Everyone has a strategy for transitions of care.
I don't know.
Yeah, okay, thank you for being
I
great.
think we have one, whether or not it's working.
Yeah.
Is a question.
Yeah, so what does your strategy look like?
Well, one strategy that we have is like when somebody's in the ED, our care coordinators by whichever clinic/providers they work with, they go down through and they see if at the end of the note they were supposed to have a follow-up visit or
Yeah.
not. And then we check to see if they have one, and if they don't, we make sure the medical secretary knows that they're supposed to have one.
Right?
So that's one strategy.
Okay, this is a definite strategy.
It's kind of the same
It's a
thing.
process, right?
With when people are discharged, there is a follow-up appointment made with their primary care, and if they don't have one, then they send them to the care coordinators to help them establish care.
Okay,
We have a policy and a process in place for transitions of care, whether they're going into or out of some other setting rather than home. It's a follow-up within 24 to 48 hours by either the care coordinator or the wellness nurse, and we do communicate with whoever the staff is and try and attend discharge meetings if possible. The problem is that we don't always know, and
Right.
the onus is on us to try and reach out. We're hoping that patient ping, which is an ADT alert event notification system, once we get on that we'll actually know, because it's just the hospital, the ED is busy, and it's not on them to let us know, and we're not connected to the EHR, so we don't always know when people go, when they transition from place to place, and if they show up back home at 6 o'clock on a Friday with a bag of stuff, we may get their after visit summary, we may not, and that's tough.
Right.
So we have a process and a procedure, and we do the best we can.
That's a big problem, I think, with the SASH coordinators, because a lot of times the hospitals are trying to clear out their patients before the weekend, and they don't get a long notice, and
Yeah.
you know what I mean? It's Friday
Yeah.
afternoon.
so it's funny, I'm so often teaching frontline staff, but now I have a room full of supervisors and managers, and maybe I even need like whoever you guys report to, but I always want to say, so what could you guys do? Is there anything you could do? Because there's zero blame here. Anything you guys could do in terms of building those relationships? And obviously, EHR, HIT, all that stuff is going to help us tremendously if that connects us and we get notifications about patients who are in the hospital or the ER. But what else? Is there anything else that you think, or has anyone done this already? I mean, it's relatively small here.
We've set up stuff before at my small hospital that's worked. The problem has been that it's always hinged upon this person doing it.
Right,
And so when that person isn't in that job anymore,
right.
we go back to square one.
Right.
We haven't built a sustainable system.
Right, so I'll just throw out some ideas, which is that I would say that you guys need regular meetings with all your partners, and certainly any of the hospitals that the clients you serve would end up in, you need ongoing, and I don't mean like weekly, I mean like quarterly or every 6 months, you need to go and meet with someone in the ER, someone in leadership at the hospital, right? Like I know everyone's like, oh, are you kidding? But those kind of like bridge building meetings kind of has to come from you and not really so much your staff, although your staff may just on their own, like when I was a midwife and my patients would deliver at the hospital down the block, I would call and say, hi, it's Carla, the midwife, and I work at 158. Is Nurse Nancy there? Oh, she's not there. Hi, what's your name? Like I would try to, if I have a patient and I send them again, could I ask for you? Who should I ask for? Like I would try to build those contacts in, and I know it sounds a little bit naive, but it surprisingly worked a lot of the time. Yeah.
There's a new initiative in Vermont through Economic Services with, I mentioned earlier, this integrating family services. They meet, I'm only speaking for Addison County right now, but they meet quarterly, and the members are education, the mental health, CSAC, the mental health agency, the Department of Health, Economic Services, sometimes vocational anyone that touches a family's life.
Right.
I know it's not hospital related, but
This
it's the
is good
same concept that
Yeah.
they meet quarterly, they talk about the trends in the county, because the belief is that if a child is struggling, for example, in school, chances are the family is struggling. What's going on in the family? There's domestic violence. Now the mental health agency comes in. Yes, we're seeing that family.
Right.
Now there's drug addiction. So it just, all of a sudden, with that wraparound service, you're beginning to see what the needs of this particular family is, which actually represents a larger group of folks in the county.
Right.
And
Great.
it's, you're maybe talking about one family, but you're really talking about, in general, the conditions of a certain group of folks. But the same thing can happen at any level with any organization, even if it's a group of hospital staff getting together with their mental health agency in their county and their emergency services in the county. That might be a nonprofit organization. And it just, the same thing can happen where it's amazing how much you find that you have in common, and then also where the holes are in your county that perhaps as a group can be filled together.
Right. Right. I think you would be surprised, right, to see how many hospital folk, for example, would love to know like who they're supposed to call or who they're supposed to be in touch with or what is a contact person for a particular place. But yes, it's great that you're having those community type meetings with those stakeholders. Yes.
So we have some pilot programs at Blue Cross. We work with discharge planners. So our staff and the discharge planners at the hospital are working together on the discharge plan before someone's actually discharged.
Great.
And we have some, we have a lot of say in that. And we have guidelines, but getting them to understand it's just a guideline. 80% of the people might fall into that guideline, but we need to know from you what's preventing them so that we can work to get more days or get the services that they need, because we don't want them discharged without a solid plan.
Right.
And especially with our mental health, like one of our biggest mental health hospitals, they're often discharging people not to their community, but to, not to the hospital's community, but to
I've heard
their other
this.
communities.
Right.
So
Right.
it's really important that, and changing that conversation has been huge.
Yeah.
Like, you guys are really serious. You really care that the person is set up. Like, we'll pay for 3 extra days if that's what it's going to take.
Right, because you're
But
going to pay
let's
for
work
the
together.
back end, right?
Yeah.
If they're discharged out onto the street
And
or
then
something.
how do we
Yeah.
make this introduction to the patient to us? So we do that over the phone, so that they know that you can call us. I'm a nurse at Blue Cross, or I'm a social worker. You can call me. So when you get home and you're struggling, call me.
Right.
I want to be able to set things up for you.
Great.
We're another resource for them.
Great.
So.
Our community health team is, in some regions, they're embedded in the primary care offices. With our community health team, it is actually administered by the hospital and run by the hospital. And although we had tried meeting on a monthly basis for the discussion about patients, that was difficult because the members of the CHT all are part-time, all are stretched, but what was very useful, and I think Ona will agree with this, is that Jen, who is the administrator for the CHT, she has introduced us through monthly meetings to various other organizations in the community. And they've actually come into our health center, spent an hour discussing what they do. And we didn't know some of these existed. And Ona, I don't know, you might want to elaborate further on
And the
that.
great thing with that is that we also started developing some really great communication between
Yeah.
the agencies.
We do something similar, a guest speaker twice a month at our extended, and I've not had anybody I've asked turn me down.
Yeah. No,
I mean,
nobody's going to turn
literally
you down.
we've had, pick an agency or a community service outreach program or a funding source, and they've all said yes and made it happen.
Yeah. We
Great.
just had Hunger Vermont come to Blue Cross. It was amazing.
Yeah.
Amazing.
So this is your work, right? As managers and supervisors and leaders, you have to lead the charge of bringing groups together, having regular meetings, having regular discussions, right? Your on-the-ground staff cannot be expected to do that. Okay. So staffing models. Again, no disrespect to you guys doing telephonic, but this is just from some research I was doing. So there was a program in Academic Medical Center. They did a big research study in St. Louis, and they actually showed increased costs for telephonic care management. Then they reconfigured their program to have more in-person contacts, and they used a model where they supervised care coordination assistants, unlicensed staff, to handle lower risk, so all your care coordination people are high risk, but the lower risk of the high risk, right, was handled by unlicensed, and then they had nurse care managers supervising them, and they showed improved outcomes, decreased cost. Other staffing models that have shown success, and really there's a lot, I just put a couple up here. Cambridge Health Alliance, I don't know if you guys know them, they're great, they have a fantastic toolkit. If you've never seen it, you should Google it, Cambridge Health Alliance Team-Based Care Toolkit. That talks about care management and care coordination. They use a nurse and a social worker dyad who kind of goes out into the community, works with the MD. They showed a big reduction in hospital stays and cost. And then, you know, specific teams led by, who are focused on homeless patients with linkage to housing, primary care and mental health. I feel like you guys do this here, led by social workers, have shown a lot of success. But I think my take-home message here is to really, if you've never looked at your staffing model and thought, like, is this the right staffing model? Then you should. It may be that your staffing model is correct, and it may be that you don't have a lot of wiggle room, but I see this even in my own agency. We're not a healthcare provider, we're a nonprofit. You know, it's like we work with the team we have, but if we could just start anew, we might set it up differently. You know what I'm saying? Like, so, and that may mean that you don't change things until you have an opportunity to hire, someone leaves, but maybe you need a social worker, not a nurse, or maybe you need 2 unlicensed staff instead of a social worker. You know, like there's ways. You have a certain amount of money to work with. You want to look at your patient population and think, is the staff that I have and the skills that I have, does it match with the people that we serve, and is this kind of the most efficient way to do it? So think out of the box if you can, it could be helpful. Okay, so recruiting and retaining staff. So consider all types of staff, right? There is no exact model. You know, CHWs, medical assistants, navigators, they all can be trained to do great work and take on, you know, caseloads with supervision. Think about what kind of administrative work are people doing, right? So hopefully, I never know how to say this without sounding like, I once said this and I really offended someone, but I'll try not to say it this way. Like, a nurse or a social worker probably should not be making appointments for patients, right? Like, like you can have somebody else do that. You can have an unlicensed person do that, do it very well. It's different if they need to have a conversation and triage and find out what's going on with them, make a clinical decision. But just think about, are you using everyone to the top of their abilities, right? You don't have a lot of resources, you don't have a lot of staff. Can you take some work off your licensed staff plate and give it to other folks that you train and support so that the caseloads are more balanced?
Carla, can I chime on
yes.
that too? So I do very little with staff who are licensed, and almost all the staff I work with are case managers or outreach workers and so forth. And I think we got a lot of pushback initially from clinics, sort of being like, who are these people? And like, they're not licensed, should they be doing blah, blah, blah? And what I find is those folks are the most effective in working around issues of behavior change. So, you know, it's not that they're primarily focused on medical education, but really helping people think about barriers and address barriers and strategize, because they have the time and they to really build a relationship in a different way. So, you know, and they'll be like, well, everyone just thinks I'm the person who can make phone calls. And it's like, no, actually, you know, leave the medical stuff to the medical professionals and let the community health worker folks do
behavior change, support that supports behavior change.
Right, and you want to think in teams, right? You don't want that community health worker, whoever it is, to be sort of totally on their own, right? They need the support of the clinical person, depending on who you care for. But like Julie said, there's a lot that they can do. But again, as supervisors, think about the tasks that everyone does and how it's distributed. So I know this is a hard one. Maybe you do this. Seems like more in the care coordinator social work area you do this, but you need regular meeting time for your staff to talk about cases, right? You need meetings to talk about meeting stuff, right? Which is different from case conferences to talk about cases. So social work people tend to do that more. Nursing tends to do it a little less, right? At least in my experience. But people need to be able to talk through what they're seeing. They need guidance, and they also need a place to share, right? They're dealing with difficult issues, upsetting things they can't change. So in terms of retaining staff, I would argue that this is right up there with how much you pay them, right? Because it's about support.
Just wondering if there's some information about numbers or how big that group is. I have staff that's in a lot of different places and I can meet with them, but I think there's a benefit of pulling people together. And just wondering if in that there's like, you get more than 8 people trying to do some peer.
In terms of sharing cases?
Yeah, about case consultation or just getting that peer,
That's a really good question. I don't know, Julie, do you have thoughts on that?
Yeah, I mean, I think if it's too big of a group, it may be good for talking about specific patients, but not so much for people. I feel like if it's more than like 8 or 10, then you just plan a bunch of small group. So, do pairs or trios and let people consult with each other in a more structured kind of break it up way.
Cool, thanks.
Okay. So, have a training and staff engagement strategy. So if you don't actually have a specific strategy for training and engaging your staff, you should start thinking about one. What are turnover rates like for you guys? Are they good? Are they not good? Are they in New York? I think it's pretty bad. Like people are not because of any, just because people are so burnt. So just some basics in terms of stuff that just from what we've seen, research. I think, right, everyone needs a clear orientation. It sounds silly, but some people don't actually get one. How are patients enrolled in the program? How do we conduct an intake, an assessment? How do we do a care plan? Motivational interviewing, we were talking about, Stephanie and I were talking about this before. It's kind of a core skill for care coordinators. And it's not a one-shot deal. It's not like a one-time thing, like one and done. It's not something you can learn in 2 hours. It takes a bunch of days, and then you have to keep practicing it, and then you have to come back and you have to learn it again. And so somehow, you need to be thinking about how can we get motivational interviewing on a regular basis to our staff, because they need it, right? Motivational interviewing is about engaging their clients. It's a core skill, because if we can't engage as care coordinators, game over, right? That's the whole thing that we're doing. Care transitions training, so some kind of specific training around, and we did it in our core training, like best practices around transitions of care, right? Kind of typical failures, typical mistakes that are made, and how do we address them. At the beginning, you really need to give one-on-one support, like let's say in the first 3 months, to people who are working with, with patients and clients, and case review, so that they have a sense of how they're doing, and getting feedback. And we've already really talked about this. You want to keep thinking about face-to-face interaction between members of the care team, whether that's case conferences or introductory meetings with doctors and other agencies and people that they will interface with. So you can make your care coordinator's life easier if you kind of open the door and do the introduction for them to meet who they'll be working with, right? As opposed to putting that on them, right? So you can invite people, plan those meetings, introduce. Does that make sense? Yeah. All right. So caseloads. Everyone, everywhere I go asks about caseloads. And, there is no correct caseload number. I wish there was. You want to, because like obviously, if one caseload is 100 diabetics and another caseload is 20 people with serious mental illness, like those caseloads are different because the needs are different, right? So we can't, there's no way to say like this is the perfect caseload. The literature shows that the thing you don't want to do is have one person or certain people who have all the crazy high risk cases and other people don't. You want to try to give a mix. And what this really means is reassessing on an ongoing basis the risk level of the individuals that you care for. Right? So how many of you guys have some sort of, it's so loud, right? It's
I know.
I'm sorry.
We need to laugh a little bit more.
I know, right? How many of you guys do some sort of risk assessment on an ongoing basis of the individuals you care for?
Yeah.
And do some people not? Anyone use a score, red light, green light, yellow light, you know, like any kind of way of saying like, right now they're in a crisis, they're super high risk, or right now they're okay, they're kind of, you know, maintenance phase. So if you don't do this, this is something you want to think about introducing. There are many risk stratification tools online. Cambridge Health Assessment also has a great risk stratification tool. I think we shared some in our earlier core training, but it doesn't have to be perfect to start doing this, but there is value in looking at what does your case mix look like and redistributing.
And it's interesting to think about redistributing as people have trusted relationships with people and just say
Yes.
the luck of the draw, those people all start to have crises at the same time.
Yes.
And it's hard to say, in the middle of you become high risk and now I'm going to give you a new person because they, you know, I mean, that's an interesting.
Yes, you're right. So I don't say it cavalierly, and right, it takes a little sophistication to think about like, hey guys, hi. You know, if you can just move someone or not.
But also we balance the caseloads when new people come in. So like I know on our team we have particular staff that have particular knacks. So then you look at the caseload and you're like, oh my God, everyone on your caseload right now is dual diagnosis. And that means all the new dual diagnosis people who come in get assigned to a different person. And when I get the like jovial older women who are really excited to have services, I'm like, okay, that goes to the person that has all of the like schizophrenic, crack smoking, diabetic. Because I mean, my experience of trying to transfer people, unless their staff person is leaving, it usually doesn't go well. So you want to balance with new people.
Yeah. Okay, that's a good tip. All right. So again, it seems basic, but I am amazed at how many organizations I go to who don't have a job description for their care coordinators. If you don't have a job description, make one. If you have one, take a look at it. Does it look like what the job is? If it doesn't, update it. I mean, again, so basic, and yet it's nice for people to be able to see a list of everything that they're doing, what their responsibilities are. There's some work involved in updating a job description, but that is beneficial for you and for your staff in terms of thinking about what the work is, and it helps maintain morale. The other piece here is that there's this kind of dual expectation of both managing and coordinating care for the individual is kind of one chunk of work, and then the other piece of it, right, is maintaining contacts and relationships with all the other people who are going to interface with this person. Did you want to say something?
No, I'm just letting you go 5 minutes.
Yep.
Oh,
I know, I'm not going to do my measures thing till,
Okay.
we'll talk about it.
Oh, so I was just going to share really quickly anecdotally. I was on this national workforce development, whatever, task force or something, and they found that care coordinator defining that is so controversial and mixed. They dropped it. This committee couldn't even do it, but they found middle manager was easier to define. You could just define what is a middle manager. But care coordinator was like, no, it's way too controversial and hard.
Well,
Like, dropped it.
People are doing different things. There's care coordinator, there's care manager, care navigator.
Is it a nurse care manager?
Nurse,
Or-
social
yeah.
work. I mean, try training, you know, I get it. But it's
Right.
still, for your place,
Yeah.
your job description, it's worth doing this.
Right. So anyways.
And when you're in a small organization, primary care, You know, a lot of your staff are involved in the care coordination. It's just, Ona is care coordination and working on a specific project and heading up that. But all of your support staff, your clinical support staff, to some degree is involved in that care coordination.
It's true, but this is exactly one of the reasons that people can their morale can start to get bad, because they don't get, like, well, that medical assistant does this, and that social worker does this, and what am I supposed to do, and what's the difference? And all of a sudden, that social worker's being weird to me because I guess I stepped on her toes, because it's not clear to me right? So this is why we have to do some thinking around what are the roles. Yeah. So building rapport with doctors. I don't know if this is an issue for people in the room. I have heard it from folks up here. I've seen it all over the place. You know, I have things down here, and it feels a little bit like when I wrote it, I was like, oh, why should we have to do that? We should not have to explain these things to doctors, and why are we, tiptoeing around? But the reality is that this is a big culture change, and I'm sure you have some very progressive docs here who are into the idea, but you have other docs who just don't know what care coordination is, or they don't know what a care coordinator does. They've never met one. They don't know what the training is. They don't know what the outcomes are, right? Docs are taught to look at data and evidence. They're like, we don't know what you're doing with our patients, so we're not really sure that we trust what you're doing. So the literature shows, and I have been on many projects where we've worked on this, meet face-to-face with doctors. Meet face-to-face with them over and over. Do not assume they know what you are doing. You, as the supervisors, need to begin that introduction and find ways to get your care coordinators in the same room with the doctors that they work with. New staff comes on, you have to go through the same thing. You have to keep building those relationships. And then you have to do like tricks, which is things like, I didn't mean that way. Totally came out the wrong way. Like, share stories about how your work has affected patients. Show any data, reports, evidence, anything you can show, like ER visits are down or inpatient admissions. If you have that, show that. Talk about what you will actually do, what your staff will do with their patients that you're coordinating care for. Show them how to reach you easily. One phone number, one contact, right? Docs will say, if you talk to them, like, I have 18 care coordinators. I have no idea who's with what patient. I have no idea how to contact them. Like, I give up, right? Anything you can do to make it easier for them to make that link is a good thing. Some docs, it's better one-on-one. Other docs, it's better to get them all in a room and do a little presentation on what you do. But this is really key. You need to build these relationships if you want your staff to be successful. And then keep the docs updated on what's going on with the patients, right? Send them notes, give them phone calls, make friends with their nurse, give them updates, keep them in the loop so that they don't lose sight of who you are and what you do. Okay, I think this is my last slide. So QI, engage in quality improvement and use data. So this is really about, part of your work is that you're going to be constantly trying to improve what you do, right? This is not, again, a one-time thing. Your role as a manager and supervisor is to be troubleshooting and thinking about how can we do better, right? And a lot of the work I do is helping organizations transform, and really in like that very small, tiny way, PDSA, that's about identifying a problem, brainstorming around what might be going on, proposing some solutions, and then testing them on a very small scale, and keeping what works and throwing out what doesn't work. And that's an iterative process. Don't take on too much. Don't take on 10 things all at the same time. Don't roll everything all out at once. Stay small and don't be discouraged by that method, because it works. And big stuff sounds flashy, but usually does not work. And bring in all levels of your organization to understand a problem, right? The front desk person may understand a lot about why patients are not staying with you more than the care coordinator does. So all levels of the organization, you want them giving input.